These materials, as well as the verbal presentation and any discussion, set out only general information. Not
Conference is now in silent mode. All participants are muted. Press *1 to unmute your line.
Okay, sorry about that. I've muted the lines now. Can you still hear me? Perfect. So the format of today's webinar is we're going to go through the case presentation and summary, and then we're going to open it up to the group for clarification, feedback, and discussion. Following that, we will go through the updates in current literature as well as recommendations by panelists, and then final thoughts and questions. Okay, now before I hand it over to the presenters, I just want to add a few polling questions just to get a sense of today's group. So the first question is, what is your current discipline? The list is very long, so be sure to scroll all the way down. Okay, great. So it looks like the majority of the group are registered nurses, as well as quite a few tobacco quit specialists and health promoter educators. The second question is the type of organization you currently work for. Looks like overwhelming majority from public health units. And the last question is asking the area in which your organization serves. Oh, so it's pretty mixed. I see there's also significant amount of working outside of the province of Ontario. If you wouldn't mind just typing in the chat box what area you are from, just so that we can get a sense, that would be great. And now I'm going to hand it over to the presenters to take a look at the case. I'll be up there.
You're doing it. Okay. Moving. All right. Oh, I'm just cozy.
Perfect.
Okay.
Perfect. Okay, great.
Okay. So I'll go ahead and present the case. So the case that we have today is pertaining to a 15-year-old female who presents with a history of anorexia nervosa and generalized anxiety disorder. So her family physician is concerned about further management and has referred this patient onward. So the history that she's provided to us is that she started smoking cigarettes at the age of 13, and she's currently smoking approximately 10 cigarettes per day, smokes daily, and has been smoking daily for approximately 1 year. She denies any other source of nicotine, specifically denying sources such as e-cigarettes, and other forms of tobacco, and says that she's never tried NRT or tried to quit in the past. She lives with her parents. She's a grade 10 student at a local high school, and she's in the academic stream, and she has not been attending classes. When you ask her about what she'd like to address, she specifically reports that she'd like to address her anxiety, the eating disorder, as well as her substance use. When you ask her further about her substance use, she states that she uses tobacco, cannabis, and stimulants. The stimulants that she refers to are crystal methamphetamine, amphetamines, and prescription medication for ADHD. She states that she's motivated to continue smoking, mainly to maintain her low weight. And so in terms of her overall motivation to quit, that's fairly low at this time. So in terms of the overall history, she reports that she has been having increasing panic attacks and also escalating substance use. She's reporting that she has been restricting her intake for the purposes of weight loss, and she's also been using substances intentionally to also keep her weight low and restrict her intake as well. She does not report any other medical conditions. Again, so her history is that of an anorexia nervosa, anxiety, and polysubstance use. And in terms of medications, her family physician has started her on fluoxetine, 20 milligrams daily. Okay, so just in terms of brainstorming, how would we approach this client given her comorbidities? So specifically that of the anxiety, anorexia, and the polysubstance use.
So please type in into the chat box about how you would, what are some of the things to think about? So we can see a lot of great suggestions coming up and what, you could do. But I guess one has to come to this in so what is primary and what is risky. So some, a young person with anorexia nervosa can be life-threatening. So anything that's life-threatening needs to get addressed first. So I mean, maybe you can tell us, does this client need hospitalization because they're medically unstable, and they, so there would be the need for involving a physician or, admission to a hospital because it's metabolically quite sick.
So, and that's exactly, I think, in terms of a few comments that were made around prioritizing. I think that's the first thing that's paramount in terms of establishing the medical stability portion of her presentation. So that, I think that's where we would really look to her family physician, the person who's been following her regularly, to see what her trajectory has been. It seems from, at least from the presentation, that this was someone who has been followed and that historically she has an eating disorder and that she's been trying to maintain low weight. And at this point, from what we understand, she hasn't been hospitalized. But that would definitely be a part of what we want to establish, right?
Right. And has she also, been referred to an eating disorder program? Has she completed any treatment for the eating disorder, and therefore she's maintaining a low weight, or she's actually never been treated?
So from what we understand is that she's been treated, and now we're at the point where she's in what we call a weight-restored condition, where she hasn't completely recovered, so she's not in full remission, but we're in more of a maintenance phase. So she definitely would have that kind of variability in terms of her presentation.
So I guess what people have said online, obviously, you know, you need to prioritize all these different things. So people have identified everything as, you know, where, you know, but I guess the difference here is that she's using smoking as a way to maintain weight. And of course, how do you know, get her to address all her substance use? So the other question is, does she need admission for her other substance use, and then you integrate tobacco in it?
Right.
Is that what we should be doing?
Yeah. So I think that's a really valid question in this case. What I would suggest if I was seeing this patient is to take a, kind of that broader look at the extent of her substance use in terms of the severity and the overall function. So in this case, she did allude to the fact that she is missing school. So exploring where there may be some dysfunction and kind of thinking about it from the context of how much of her use is interrupting her overall life. And I think that would be a good way of deciding whether or not she would require more intense treatment, being, in this case, inpatient, outpatient, in this case, concurrent disorders type of treatment approach.
And so also, I think as Natalie here says, you know, providing her written information. And, you know, people can have significant cognitive effort, you know, effects of the substance use, of the anxiety, of the anorexia, depending on where they are. You really need to make sure that they can actually, you know, incorporate the information we're telling them. One of the things with crystal meth is that the brain effects of cognitive effects persist months after somebody has stopped using them. So the person may not be, they may seem to be understanding what we are saying to them, but it may not necessarily take hold. So given what's going on, I mean, I would be thinking admission for the substance use, even if the anorexia is stable, or like ideally to an adolescent concurrent disorder unit, if not inpatient, but at least a, you know, intensive day hospital, day programming at least, so that they can actually get better. Yeah. So I think the other issue is, you can't hear us. Okay. Sorry, we will talk louder. And again, the root causes. So thinking about the root causes, generally what we talk about are obviously the ACEs study, so any adverse childhood experiences that she might have had. You know, what is the history of trauma in this situation? I don't know if you have that information, but again, trauma is a big associated factor. And again, genetically, family history of anorexia or other problems like that.
So we don't have
Hi, it's Carolyn here. Yeah, and I just wanted to add to that. I mean, I think that's what stood out for me with this case, too, is sort of what's her social environment like, you know, in terms of family and negative and positive influences, particularly at age 15. You know, who is she associating with? What's her peer group like? And then again, as you mentioned, what factors kind of led to the development of those concerns that we have now?
Right. So I think a really good approach here would, and of course this depends on what setting you're in, but if you can incorporate, kind of getting into the literature, but the idea of the HEADS assessment, where you do go through all of the various psychosocial aspects of an adolescent's life, where you're asking about their environment. You're asking them about their school setting and their academic trajectory. You're asking them about their peers. In this case, we would ask more about her eating. And then D is for drug use, substance use. And then essentially getting at some of the elements that you're bringing up in terms of delving in a little bit further into the history. Then this, of course, would be in the context of also asking about family history as well and her past medical history. Although we've said that she doesn't have any other conditions, oftentimes we find that, especially if we can get parents involved, that we hear about, you know, previous admissions that have happened over the past few years, maybe for an overdose or for things that they may not necessarily consider an actual past medical concern. A really good example is head injuries or concussions are often overlooked, so that may play into the cognitive deficits as well.
Okay, so So again, I think the question number 3 is the strengths that you could elicit, and I think we have one comment about strengths about Natalie responds to you. Look at what our coping strategies that are strengths-based, because she's probably getting a lot of negative, focusing on her deficit. So to engage her, keeping an eye on what has been healthy. How do you amplify that? Okay, she's been through a lot in this life. Yeah, absolutely. She's only 15 and she's got significant psychopathology, but often what you will see is that the other substances may be acute now, but the tobacco will persist for a lifetime. And I think looking at it and putting it in, is to put it into the context of her whole life as she's coming on, but there's a prioritization of immediate versus subsequent issues that you're going to address. Okay, I think we should. Is there anything else you want to add, or should we move on? Okay, let's move on to the next slide. So I'm going to ask Tanya to just flip the slides. Okay, there we go. Thank you. So when you take a look at anxiety, I mean, anxiety is an interesting condition. All of us have experienced anxiety at some point. Whether we've had an anxiety disorder is a different matter, but an anxiety is, it's an uncomfortable, it's a negative, it's a dysphoric feeling of often goes along with fear, worry. These are some of the words, and then you may have physics, so that's more the psychic experience of it, and then there's obviously the physical aspect that anxiety can trigger, which is your flight or fright response. So it can make you feel like you need to run away, you feel your heart beats faster, you sweat, you get dry mouth, you feel you may pass out, you may not feel real. So all of those things can go with as an anxiety disorder, and of course when it comes out of the blue without any warning, that is again becomes problematic, and then people end up with phobias, etc. So when we take a look at the broad category of anxiety disorders, other than obsessive compulsive disorder, anxiety disorders have a high rate of tobacco use when you compare them to the general population. And in fact, people with anxiety disorders are much more likely to even have problems like alcoholism, because obviously they're looking for ways to self-soothe. But why would somebody who's anxious and feeling kind of on the negative side of things find tobacco use to be comforting? That's kind of odd. Nobody takes a stimulant to calm down. So one of the things is with patients with anxiety disorder, you have to disentangle what is caused by the withdrawal from nicotine. As you know, nicotine has a half-life of about 90 minutes. And every time that level of nicotine is dropping, one of the withdrawal symptoms is anxiety and restlessness. So the person experiences an anxious feeling, smokes, feels calmer, and then makes the association that when I smoke, I calm down, and it's helpful to manage the anxiety. So one of the things is that patients with anxiety can be treated with medications for smoking cessation, and they certainly will benefit from some of the behavioral treatments that we offer, whether it's mindfulness-based treatments or CBT or just simple relaxation exercises. It'll help both smoking cessation and anxiety. And we talked about this nicotine being a stimulant, and so one of the main issues is to find out from the patient what is the relationship between their smoking and their experience of symptoms of anxiety. Are they getting more and more anxious the further and further they go away from a cigarette, and then calming down as soon as they have the cigarette? That's much more likely to be a withdrawal symptom. So that's just in the history. You want to make sure you check into that. So we just talked about this, and here are the symptoms that you may ask about, and how people will call as feeling anxious. They may be irritable. These are all negative feelings, so we would call these negative affects: irritability, anxious, nervous, restless, difficulty concentration. The last few are, again, an indication that this might be because of smoking withdrawal, especially the increased appetite. all the others can go with an anxiety disorder as well. So you need to make sure that patients understand this and that that's not the situation. Now, again, the addressing things concurrently really are many of the symptoms that go along with the current condition, whether it's depression, anxiety, schizophrenia, etc. A lot of those symptoms get better. And you can imagine in somebody who's got an eating disorder, especially anorexia, where they're using the appetite suppressive effects of the nicotine, getting rid of that is an important piece of getting the anorexia better. So, there's a direct relationship between that. So, and of course, if they're using other substances, quitting tobacco at the same time also potentially increases their chance of being absent from other substances, as well as preventing relapse, but it could be a reverse causation effect as well, that the more likely that people are able to stop other substances, they're also more likely to stop tobacco. But as a clinician, we should not be excluding that and saying, well, you can keep smoking, but we're going to, stop the other more dangerous drugs. It's not a trade-off. That's a false dichotomy. We should be offering addiction treatment that is inclusive. Just because it's legal, not legal, it is something to work through. And again, as we talked about it, over many times, is the drug interactions that occur with psychiatric medications. Now, in this situation, the patient was on fluoxetine that does not get affected by tobacco smoke, but and most antidepressants don't. But it is something to keep in mind when we're dealing with psychiatric medications. So this is a fairly a prevalence study looking at lifetime prevalence of smoking prevalence rates in people with anorexia, and it's about a third. Bulimia a little higher, binge eating disorder even higher, and you can see that smoking and tobacco is a means to control weight, and it's generally thought why people smoke tobacco as a way to maintain their weight. But here's the kicker. Right now, if you take a look at current smokers who we are getting into many studies in Ontario and across Canada, their BMI is actually in the overweight and obese range. So our current smokers, essentially, smoking is not an overall effective population-based way to reduce weight, although many people will use it as a way to suppress appetite. And again, when people have other issues with anorexia or weight issues, they use smoking as a way to cope with stress, and overall, there's less desire for cessation, and part of it could be is to moderate the hunger and weight as well. So part of it is in treatment, and I know that this is not common in most eating disorder programs, is that they do not address the tobacco concurrently. So it is important for us to pay attention to that piece and integrate that tobacco use, because it is actually a way to manage weight. And you're trying to get away from all those behaviors as part of intensive treatment. So the main issue is increasing motivation, promoting healthy eating and a body image as well, and tobacco interferes with that. So I don't know if you want to add anything to that.
Add one thing about that, just to emphasize that point. I think part of the reason why these aren't addressed is that we aren't necessarily asking, because we're focused so much on the eating disorder that when we see the individual in clinical settings, we're focused on their medical stability and really around, what are they consuming and how they're trying to manage their weight, and we don't go back and kind of get that history again. Has anything changed over the last, while since we've seen that patient or that individual, that client? So I think it's really important, especially with adolescents, because their situations are so dynamic. They may be just, using it experimentally, quote unquote, for a moment, and then all of a sudden, that things may change, and they may be using more than they may have previously even admitted to in their, in the previous encounters. So I think it's important to always address those things as part of your screening.
Yeah, and I think Leslie Walters said some of the psychiatrists that I work with feel that clients who decrease or stop smoking complicates their ability, medication regimens, and so could you clarify that last bit, what you mean by that? Complicates their ability medication regimens and tends to address everything. So ignoring smoking is a common thing in psychiatry, and trying to quit smoking complicates the medication regimen. It's not rocket science. It's easy to do, and in fact, quitting smoking will increase the appetite naturally. So why would you not want to do something that brings the appetite back? Can you think about it? If you think this out aloud, let me allow you to continue something that allows you to have the symptoms for which you've come to get treatment for, which is anorexia. So how does that make sense? And I think these are some of the challenges that we have to overcome through knowledge and education, in challenging some of the gaps that exist in medical training about how to address addictions overall and tobacco in particular, which is rampant. And I think it's only through education will we be able to change these outdated attitudes and knowledge that people have, because you can see so you're giving the person a medication to improve the appetite, but you don't want to take away the medication that is causing them not to have an appetite, which is a dirty delivery device of a cigarette, which has carcinogens, which has acetaldehyde, all these other things. So it makes very little sense to be saying, to me, it's like trying to mop the floor with the tap running. So, turn off the tap. And if you don't know how to turn on the tap, get help. Because there are people out there, as you can see, who are now starting to pay attention to these things. Okay. So again, this is the motivation interviewing as a mechanism of engagement. Now, one of the things that, and we do know that there are, depending on the severity of the anorexia nervosa, there can be cognitive deficits that may or may not respond to CBT or cognitive sort of interventions.
Yeah.
And so there is, in anorexia, there may, now hopefully it's not as young as 15, but there is a point where
even younger. So.
You can see it.
Yeah. So what we actually use is the weight, is the percentage of what would be deemed as their ideal weight in adolescents and children. And there's kind of a roughly a percentage that is associated with what we would understand to be cognitive deficits, and therefore at that stage or that time, that would be a time where we would not be engaging in any form of therapy,
right?
Individual or family-based therapy, for that matter.
So it would be purely behavioral and pharmacological treatments at that point, because cognitively they're not able to manage it, right? So this is I mean, it doesn't mean that we become mean to them. It doesn't mean we get rid of the spirit of motivation. You can still have the spirit of it, and you still can have compassion and acceptance of where they are at, and try to evoke from them and partner with them. But it's not going to be. Don't expect a nice cognitive behavioral therapy kind of result that you would get with somebody who's cognitively intact. So again, these are some of the things that we've done, and we won't spend too much time on this today because we've talked about motivation training many times. But just to summarize very quickly, we looked at engaging, focusing really on engaging the person and keeping them and coming back, trust, making sure you build the trust, trying to focus on what matters, evoke from them what their reasons for change are, and again, when they're ready and able, with all the caveats you said, plan for the treatment. Okay, so let's open it up for more questions around the didactic piece. So we talked about anxiety, concurrent disorders. We addressed Leslie's question. And are there any other questions or comments about this section? Right. So if you have a question on the line, please press *1 to unmute, and you could speak if you don't want to type. Go ahead. Oops, you're muted again. So it's *1. Okay, not seeing any questions. Let's go on. To the, I'm surprised we have no questions. So maybe we'll just, summarize this case and maybe talk about it a little bit. So now what we were noticing is that if you can stop as well. I mean, obviously this looks like a severe example. You're going to need a multidisciplinary team. You're going to have a long-term issue. But we're noticing that even in STOP, in family, from coming out of the family health teams and the CHCs, that our young smokers who are coming to seek treatment all have a comorbid psychiatric condition. And I think this is an exemplar of what we could expect to find. Now, this is a really a complex case. So the question, I think, what is the learning that we can take away from this one is eating behaviors may be disordered. And the question I have is, should we be asking our young patients, and can that be a way to detect people who are running onto body images? And what are some of the questions we should be asking?
Yeah. So that's really a great kind of, I think, a nice segue to talk about the approach again. So let's say you have an individual who presents with substance use. One of the things that's really important to figure out for adolescents, I find, is actually why they're using it. And so this individual is quite forthcoming in talking about the fact that she's using in conjunction with her motivation maintain a low weight or to kind of maintain her eating disorder. But I think the really important piece is that there are lots of other reasons why people may be using and using particular substances, and I think that's a nice way to kind of get around that. You mentioned, we talked about anxiety symptoms and sleep being one of the things that I tend to see a lot around the use of cannabis. So cannabis being used to initiate sleep and to maintain sleep, right? Where there may be actually an underlying sleep disorder, right? So I think that's a nice kind of, just more, again, a little bit more BMI.
Yeah. So if they're walking with smoking as a young person, basically we should be asking them about other behaviors. And so in our clinic, we're going through a run-through, not only with them, but with everybody, is saying, okay, so it's just like our standard review of system. How are you sleeping? How are you eating? How is your smoking affecting your eating? How is it affecting your drinking? And if you're using other, how is that affecting these basic, vegetative functions? How much you're eating, your weight, your sleep, and then of course, your academic performance, your job, whatever you might be doing, your socializing, the family, and so sometimes it may come up that now they're doing it for weight control. And so what recommendation would you have for us in tobacco? We're working mostly, we're going to see them for tobacco. They're not going to come to us for the eating. But what are some of the questions we could ask about that would tell us that this is not just, that this is a disordered eating pattern and that we need to send them on to a specialist or make a referral?
So I think if there's a really severe preoccupation with their body image, I think that's one thing that you can definitely start to kind of get a sense of maybe this is much more of disorder type of eating. The other issues would be that fear of gaining weight. So if they start to talk about escalating their nicotine or stimulant use because they're fearing gaining weight, then that would be definitely a reason to refer. If they appear to be low weight, you may not be getting their actual anthropometric data in clinic, but you may get a sense from the way that they look.
Right.
That, again, that might go back to their family physician to see is this something that has been addressed. Do they have a family physician?
Mm-hmm.
The other thing.
Yeah.
Are they seeing their family physician? Like, those are the things that they come out of that conversation. So the biggest thing I would say is that do they appear to be low weight? Do they have a fear around losing weight or gaining weight? Or are they really preoccupied in terms of body image?
And what about, so obviously here we've used this happens to be a young female, but my understanding is that we're getting males in the same, could be in the same boat as well. So it could be across genders, and it doesn't necessarily mean it has to be a girl or a woman, right? So being mindful, so I guess if we've got a young person who's really worried about weight gain when quitting smoking, coming in wearing baggy clothes and really looks kind of underweight, and may be using other substances as well. Right. That should put, like, is there an eating disorder going on here? And typically the eating disorders we're worried about is we're both, like anorexia is where they restrict and they're trying to lose,
So are they purging?
So they're purging and eating, and so asking those questions about, young people is probably a good sort of, is it a routine screening that you think
there are some screening tools you can use. There is one that's becoming more widely used called SCOFF. And it's 5 quick questions to see whether or not this individual screens more positively in favor for potential eating disorder. So that's one screening tool that you could potentially use that's quick.
Quick, yeah. And
in clinic.
So it's something in the clinic. So it's called SCOFF. Yeah, and I know Megan has been online looking, finding it's a study. So we'll find out the SCOFF. So that may be something to think about. So here are some of the questions that we need to come about with the medication. I think we'll get to Leslie's last question about the cognitive deficits related to low weight. Is there anything in particular you want to talk about the cognitive deficits related to low weight?
Great question. So I think that the bigger issue here, just addressing your question, Leslie, is so if you were to assess cognitive deficits in the context of low weight, what I would suggest is taking a step back and actually getting a bigger sense of what their development was like, because you may be attributing the cognitive deficit to the weight where there may be other reasons. So that would be my first thought around that, is just to make sure that that's not the only reason that they may potentially have deficits in that area. And that may speak to why there may be what may appear to be resistance. So a good example is an individual who has maybe a learning disability or disorder, or even those who have attention deficit disorder. Lots of times what you'll see is that throughout adolescence, during high school years, that the deficit disorder potentially has been masked throughout their elementary school years. They've been maybe really good at compensating, and then you're starting to see this appear more so as the work becomes more challenging. And so that may be another reason why there may be deficits. And it may also be, again, speaking to substance use, why they may be seeking out a stimulant, for example, or prescription attention deficit disorder medication. So,
and smoking as well.
And smoking, of course, absolutely. So I think what I would suggest is looking to address the cognitive deficits, I would definitely take a step back and get a bigger picture around their overall presentation.
And it's interesting you mentioned this, because Trisha, in the previous ones we talked about people with head injuries. Mm-hmm. So what happens is, in generally, we often attribute it to a lack of motivation, but it actually may be a lack of ability. And the things that can affect somebody's ability would be obviously a head injury or some sort of learning disability. So it's not necessarily that they're not motivated. It's actually an ability issue. You have to have a different approach to it. So sometimes I think when we and in general, when we are faced with clients who we think they're not motivated, take a step back and see, is it really motivation per se, or is it ability? Because it might be coming through. So again, I think moving on to the next question is the Zyban and NRT patients really anxious and hyper would be helpful. Let's talk a little bit about Zyban, because Zyban is bupropion, and bupropion is a stimulant. In animals, in a very high dose, bupropion actually can substitute for cocaine. And bupropion is also used to treat attention deficit disorder, not as a first-line medication, but as a second or third line. The risk of bupropion, at least for we've been taught in the UK, is that in somebody with an active eating disorder, it's very dangerous because it can precipitate seizures. Because especially when somebody's restricting their intake, their metabolic, their sodium could be off, their potassium could be off, and now they're taking a drug like bupropion, they could tip over into having a seizure. So in general, it's a contraindication for using bupropion in people with an active eating disorder at that time. If they have a past history, it's stable, it's not an issue, the weight is normal, we will use it, but generally we will not provide that. And I guess using NRT, the short-acting ones kill appetite. The long-acting don't. So I think I would be much more somebody a patch than it would be to use the lozenge or something. But
I definitely agree with the patch and the point about bupropion. The other thing to think about, though, is, again, making sure that as you're prescribing or having a conversation about pharmacotherapy, that in the context of those with anorexia in particular, one of the criteria for when we're looking at medical stability is heart rate. So, bradycardia is one of those numbers that we're, or parameters that we're looking at when we're thinking about whether or not this individual warrants an admission per se. So knowing that NRT would potentially mask this, we want to make sure we're collaborating or we're in communication with the primary providers, like the family physician. So that's just one thing to think about. But definitely not a reason not to treat. You would certainly want to make sure that you were providing treatment as indicated.
And a very simple thing we could do is take the pulse every week.
Exactly.
I mean, that's the simple thing. If their pulse is normal, then you know you're okay. If the pulse is low, then maybe you're screening to say, what, I think your pulse is low. You need to go see a doctor. And that way, you're not. Okay. So.
And particularly, I'd say as kind of an adjunct to the medication, especially I found with anxiety and sort of hyperactivity, particularly with youth, things like arousal kind of decreasing techniques is what I use in clinical practice, like the mindfulness, progressive muscle relaxation, meditation. Those types of things I find some of the youth can be quite grasp onto them and use them in practice. And there's some good, apps and things like that youth can use as well to do that at home, which I'd like to kind of add in.
Okay, so some self-management also comes into this. So, thank you. We were trying to open up the SCOF question, and I think I have, but I don't know how to show it to you guys. But maybe Tanya can do that for us. But so let's, we're getting what's going on? Are there, when you're looking at motivation and their behavior, is it motivation versus ability, and some of the things that can affect ability could be the eating disorders, if it's that, and that they've lost so much brain weight that they can't actually follow through, or is it the substances or a combination thereof, or some other things that may be affecting their ability, whether it's a hereditary learning disability. And actually, there's one question before we leave that is there, what if he says, yeah, I was born premature and I was, in the ICU and I was born when I was 30, it was only 32 weeks when I was born, and then I spent a lot of time and I had, how is that important? How do we address that? Because my understanding is that could affect.
Yeah, could potentially. I think at this stage she probably is. I think it was grade 10.
15.
So I think that would be that question around, again, academics, and whether or not maybe a psychoeducational testing would be appropriate. Now the thing about that would be that the context being, if she's using substances, you have to make sure that you're testing the individual, and usually there's a period of time that